Good day. My name is Premila Webster, and I'm the co-editor of the Journal of Public Health supplement, Mental Health in India, Bridging the Gap. The supplement brings together some of the research related to mental health in India. So in this interview, I'm going to talk to two of the authors of the Perspectives article, which explores the opioid epidemic in India. So one of the authors is Dr. Ravindra Rao, who is a member of the Faculty of Psychiatry at the All India Institute of Medical Sciences, New Delhi, one of the leading medical institutes in India. He works in the National Drug Dependence Center, a tertiary care facility for the treatment of addiction, and is one of the investigators in the recent national survey on the magnitude of substance use in India. Dr. Rao also runs a community drug treatment clinic, which uses mobile methadone dispensing in an urban underprivileged locality in Delhi, the first of its kind in South Asia. Dr. Rao's area of work and interest include community-based treatment of substance use and disorder. The other author is Professor Bhrigupati Singh, who is an associate professor of anthropology and sociology at Ashoka University in India, and a visiting associate professor of psychiatry at the Carney Institute for Brain Science, Brown University. His book, Poverty and the Quest for Life, Spiritual and Material Striving in Rural India, was awarded prizes both by the American Institute of Indian Studies and the American Academy of Religion. He is the editor of The Ground Between, Anthropology, Engage Philosophy, and serious co-editor for Thinking from Elsewhere. He's currently working on a monograph on mental illness and health in India based on long-term ethnographic fieldwork at the Department of Psychiatry at All India Medical Sciences Institute at Delhi. Thank you both for your contribution to the supplement. I read with great interest your essay on the opioid epidemic in India and how it is different from what's happening in the West. Could you kindly elaborate?
Sure. Thank you, Dr. Premila, for that wonderful introduction, and happy to be part of this interview. So, the question, in case, if we compare the opioid use problem in the West with what is happening in India, we see some important differences. One important difference is the choice of opioids used in India and in the West. In the West, especially in countries such as in the USA, the proportion of those using prescription opioids is much higher than heroin. In India, the opioid epidemic is driven by heroin followed by pharmaceutical opioids. This is clearly seen in the recent national survey on magnitude of substance use in India in 2019, where out of the 2.1% past year opioid users, we saw that more than 50% were heroin users. Of course, this pattern also has changed compared to if we see the earlier national survey of 2004, where the predominant opioid used was opium followed by heroin. What is also notable is the fact that the source of these pharmaceutical opioids that people use in India are not the prescribing doctors, but they are the neighborhood chemist shops. As per law, these shops are not allowed to supply opioid painkillers such as injection buprenorphine, pentazocine, or tramadol without a valid prescription from the physician. However, due to inadequate monitoring, these shops sell without prescription. Another aspect is also that the figure of past year opioid use of 2.1% is, of course, as expected, not uniform throughout the country. There are some states, notably the northeastern states of India, where the prevalence is much higher than the national average. But what is also interesting is even within a state, some neighborhoods are more prone for opioid use as compared to others. Even the way in which the opioids are used may change between the various neighborhoods that we have. So, with regards to the neighborhoods, I would ask Dr. Bhrigu to please elaborate on this.
Thank you.
Thanks. Thank you, Dr. Ravindra, and thank you, Dr. Premila. It's wonderful to be part of this conversation, and thank you for inviting us to contribute. I mean, the coverage of opioid epidemic and mortality remains very US centric. So we wanted to offer a kind of corrective to that sort of US or Eurocentrism. And I think what is important is how sharp the variations are, as Dr. Ravindra is saying. So in some ways, we can see India, it's not yet a physician-induced epidemic. It might become that, and we'll say more later. But I think the crucial analytical kind of objective in this essay for us was to show how the term epidemic obscures a central problem, that of variation, that how sharply different even very similar states or regions can be in India in terms of the degree of the problem and across countries, of course. But as an anthropologist, what was of interest to me is to see the neighborhood clinics where Dr. Ravindra and his team works, and to show, as we do in the article, how significant even neighborhood level variation can be. And in the article, we emphasize that it's not just kind of just of conceptual interest, it's a matter of clinical interest, of kind of life and death. You have two absolutely similar, in some ways, demographic neighborhoods quite close to each other in Delhi, where one you have IDUs, which is a much more dangerous form of ingesting opioids. And the other, you have smokers and chasers, which is a very different kind of picture of mortality, morbidity, etc. So for an anthropologist, I think what's interesting is the causes for in seemingly a global phenomena to show how much it may vary across even seemingly similar demographic areas. But our argument is that it's also clinically relevant.
Right. Thank you very much. I also want to ask you about the role of women, both in caring for and taking part in the supply and sale of the drugs, because I found that was, quite a different and interesting aspect of your essay.
Yeah, no, thank you. So Dr. Ravindra, maybe I'll go first on that.
Sure.
So this came about through kind of neighborhood level clinical observation, seeing kind of repeated visits by patients and the family members who accompany them in spaces like clinics that of Dr. Vind and others, but also at the sort of largest level, the question our essay asks is India going through an opioid epidemic? And in some ways, just if we were to take only individual patients as the unit of analysis, then it is overwhelmingly a male phenomena. Heroin addicts in India are overwhelmingly male, and it's not only because of underreporting, it is a central feature of the phenomena. So in some ways, one could have said that, yes, it's a primarily male problem. But the moment one takes not the individual, but the household as the unit of analysis, then what we're emphasizing is that actually in mental health, a crucial thing is gender, but the question of how gender actually figures is a research question. And here it is that the burden of care, so at two levels, it is a gendered, our contention in the article is that it is a deeply gendered phenomena. At two levels, one is at the level of the household. So care and the burden of care, both for the household and for addicts who survive, as we show through our kind of clinical number of times family visits, etc., and how different that can be. It's absolutely central to the opioid epidemic that it is placing a very heavy burden on women in particular, if one understands the issue at a household level. Second, also through sort of neighborhood work, we realized that at least in North India, and maybe this would need further research, drug dealing in India is very different from the West. You don't have like people in gold chains and sort of a glamorous culture around it. It's a very, drug dealers are quite poor, and most often there are women. And but women with a kind of mythic personality or legendary stories in the neighborhood and names which are very evocative of Hindi cinema. And that's partly because, again, this will need further research from my side, I guess, to make the argument more rigorously. But they're often mediators between what could be very violent, what could potentially be a much more violent system of exchange and economic exchange as it is in Latin America, or in many other parts of the world, where gang violence and who controls the supply is really like fraught with a lot of violence, gun violence, etc. You don't see that in India, I think, partly because there are these women figures who are like often widows of other gang leaders and who maintain through two levels as drug dealers and as police informants, a kind of very delicate equilibrium between systems of exchange and supply and movement, and are often quite poor, living in the neighborhood. Everyone knows that this is where you go to get heroin, etc. So it's a very different system than say other countries. But at the clinical level, maybe Dr. Wind, could you say something more what one sees in the daily life of patients?
Yeah, I agree with Dr. Brigu's point. Uh, when we observe, when we work in the community drug treatment clinic run by our center, we see that women, either as mothers or as wives, they play a major role in the treatment of their, say, husband or son using any kind of opioids. Now, they often serve as reasons for seeking treatment, and they also are found to be a major pillar of support during the individual's recovery process. What we also see is that those with such support system, they tend to do better in treatment in terms of, say, adherence to the treatment or retention in the treatment. Now, for example, the mother visits along with the son for consultation with the doctor, collecting the medication, also at times following up with the doctors or with the clinic on behalf of the son when he starts working and is unable to follow up in the clinic. Of course, these are anecdotes. It would make an interesting case to see how much impact such family system has on the individual substance users recovery in addiction. So that would be an important area to work on and to study.
Thank you. Dr. Rao, could you kindly tell us about the work you do in the community and the challenges you face?
Yeah. As a faculty working in a tertiary care addiction treatment facility, what we have done is we have this community drug treatment clinics that we have set up so that we are able to cater to population within a given catchment area. So I run a community drug treatment clinic in an underprivileged, impoverished area of Delhi, which is in the eastern part of Delhi, where we provide treatment for opioid dependence on an outpatient basis, which means that the doctor visits this clinic twice or thrice a week, and the patient, when he wants to seek treatment, he comes to our clinic. The doctor does the assessment, and then if he's found fit to be started on medications, he's provided those medications. And the medications also, because these are controlled medications, they are controlled narcotics or psychotropics, so the patient has to come to the clinic on a daily basis and get his medications. So in terms of treatment, we have both methadone and buprenorphine that is available for treatment of opioid dependence, and as I said, it has to be provided on a daily dispensing basis. Now, apart from the static clinic that we have, 2 years back, we also started methadone dispensing through an ambulance, and this is one of its kind in the South Asian setting at least. And we started this because we saw that the patients who were living a bit far off from the clinic, they were having problem in coming regularly after the initial few months when they started working, because they had stopped their opioid use and they had started now focusing on their work and productivity. Through this clinic and the mobile van, we are able to provide to treatment, or we are able to reach out to at least 1,000 patients on any given month of opioid dependence through this small clinical setup and mobile van. So what we wanted to showcase is that even a small setup such as this, because in terms of infrastructure, we don't have a big building in this community clinic. We have taken space on rent, and it's a modest kind of a place that we have. But even such places, if you have dedicated staff and you have the right kind of medications, you are able to reach out to a larger population. Now, in terms of challenge, of course, the community clinic is dynamic. Every day is a challenge there. But the recent COVID-19 pandemic made it very challenging to run the clinic. And we had to respond to the situation whenever a new situation would arise. We had to make several modifications in the clinic operations. So, for example, major change is that, as I said earlier, that we had to provide these medications on daily basis. The patient had to come to the clinic. Now, what we did, because to reduce exposure of the patients as well as the staff, we started providing these medications on take-home basis, including methadone, which was never given as take-home in the country earlier. So the pandemic gave us a chance to tinker with this and understand how take-home methadone can be beneficial or can be risky to the community or to the patients. What is also interesting is that we have not closed down the clinic for a single day during the pandemic. So it has been running throughout, including during the stringent lockdown period. So that is something which, because of the dedication of the staff, the way we have been able to modify the clinic, respond to the challenges, we have been able to do so.
That is amazing work.
Mm.
So finally, I want to ask what your both
I'll
your
just,
thoughts.
could I
Sorry,
add
go on.
one? Sorry.
Yes,
Yeah,
of
yeah.
course. Sorry.
No, just to say that having, as an ethnographer, you get to sit and repeatedly watch clinical
Of
interactions.
course.
And I think what's been astonishing for me as an outsider to see their clinics is two things. One is that the notion of what a clinic is, sometimes we have a very sanitized picture of what
Yes.
will happen, or through in social science, Michel Foucault, we imagine it's a space of compliance. I mean, the patients here are sort of local dons and gang leaders often, and the challenge would be as simple as somebody suddenly taking out a knife to the doctor or the nurse. So the challenges are quite significant when you see a neighborhood,
Yes.
and then to see the kind of relationships that sometimes like the nursing staff will build with the patient. So in two of these clinics, there's one particular very charismatic nurse whom all the patients will refer to as mommy. And the fact that she's been able to create a relationship like that is also very much part of how the clinic becomes less challenging, more dependable, less daunting. So I think some of that, and then in the pandemic, it's, I mean, astonishing to see the fact that it ran through the entire pandemic,
Yes.
and the fact that the patients, I mean, as far as being able to track, are still alive, is in no small part to do with that kind of continued care through the pandemic.
Absolutely. So I was just wondering about both your thoughts on what the future holds and possible solutions to bridge the gap of mental health services in India, specifically related to addiction and the issues you've been dealing with.
Yeah. Should I go first, Dr. Brigu?
Yeah,
Yes,
sure.
absolutely.
I mean, in terms of future, if we look at the trajectory of opioid use in the country, it seems that the opioid use epidemic may increase. Now, we have preponderance of heroin use in the country, and closer second is the prescription opioids or pharmaceutical opioids. Now, what if one has to hazard a guess, it may seem that pharmaceutical opioids will be on the rise because we see more and more individuals coming with use of pharmaceutical opioids, say, for example, tramadol. Now, this is a difficult situation to handle because if you see some other reports, it is estimated that in India, less than 5% of individuals with chronic pain in need of opioid painkillers, they receive this medication. Now, it seems that we need liberalization of the laws and policies governing opioid availability and accessibility in the country. On the other hand, we have these pharmaceutical opioids which are easily accessed by those who abuse them from the neighborhood pharmacies or chemist shop. So creating a fine balance between these two phenomena, these two situations is going to be a challenge, and there are no easy solutions or answers to this. We have to be watchful of increasing pharmaceutical opioids in India. That is something which is there. The other challenge, I think Dr. Brigg also would dwell upon it a bit more, is the availability of scientifically proven treatment of opioid dependence, such as opioid agonist treatment, like the one that we offer in our clinics. Now, if you see the recent national survey, it shows that only 25% of those in need of treatment, they received it, which highlights the huge gap in treatment. And this is something which has been seen in other surveys as well. It has been amply highlighted. Now, what happens is, in the absence of scientifically valid treatments, various facilities in the name of treatment centers, or what are called as quote unquote rehabilitation centers, they are mushrooming, or they have mushroomed in the country, that promises addiction treatment. Now, these are private, unregulated centers that admit the patients with drug dependence for months. And we know anecdotally that there is human rights violation that is carried out in the, or punishment, for example, meted out to the patients in the name of addiction treatment. Of course, the recent Mental Health Care Act that has been passed in India can be used. There are provisions in that law which can be used to regulate these centers. But of course, much would depend upon how do we implement that and allow the treatment centers to be roped in, to be regulated in this manner. So the most important solution, what I feel, is that we need to expand and scale up the clinics that provides treatment for opioid dependence in the country. So, looking at the number of opioid dependent population in our country, definitely to require considered efforts on the part of everybody, say from policy makers, to the program managers, to the doctors, to the implementers to make this treatment available throughout the country. That is what I feel. Dr. Bhrigu, your thoughts?
Thank you.
Thank you, Dr. Ravindra. Well put. There were, I guess, 2 points, both related to what Dr. Ravindra just said. So one would be in relation to future trends in treatment. I would say in our role as, say, non-clinicians writing about these issues, one of the critiques you encounter often of opioid substitution treatments, people will say, that's also an opioid. It's just substituting one opioid for another. But the life and death difference there is that depending on how it's modulated, the dosage, it can be the difference between survival and death, or between somebody being rehabilitated and re-entering an economy or a household, opposed to abandonment or death. So I'd say this kind of model of outpatient OST treatments is entirely different from the danger that Dr. Ravindra is pointing to, that we've noticed together but not known quite how to write about it or research about it, but we'll try, which is that in India, there's an absolute mushrooming of these things called Nasha Mukti Kendra, de-addiction centers. And they're advertised often just on a tree or on on an auto rickshaw with just a phone number. And there's a reason why they have such little information being promised, because they're basically spaces of incarceration. But somebody, you'll just call them up, a group of 3 people in a place like AIMS, you have to consent to treatment. In a Nasha Mukti Kendra, you don't. 3 people in so-called lab coats will land up to take your son away and shut him up for 6 months. And families may avail of that because it's what they think is the way to discipline and member of the household. So it's a quite dangerous thing that's happening on a very large scale, and there's absolutely no regulation of what happens inside these centers. And we keep hearing reports of deaths and violence, etc. The second thing I would say, so one is that it's not that in the absence of this kind of clinical treatment, what you have is quite a difficult situation in which there are alternatives. The second thing I would say, that from a research perspective, what I'd say I'm interested in, and hopefully it's something we'll try together as well, because our work in these neighborhoods continues, both clinically and ethnographically. So our next phase of research that I'm interested in is thinking about cultures of chronic pain in India. And why is it actually that there isn't more? Sometimes that surprises me, given that India is among the world's, or is possibly the world's highest consumer of antibiotics. I'm surprised that actually it's limited to heroin. And that is that even if it isn't physician induced, it may well happen that the availability of opioids has only increased since 2014. Until then, there was only one opioid tramadol available. Now there are many more, and it's increasing. So will there be a surge or a next wave? We don't know. But even till now, what contains the wave is partly cultures of pain, or the way people deal with chronic pain in India might be quite different than how they deal with it in the United States. So I think as a researcher, I'm interested, and we try and follow together, hopefully, how one understands cultures of pain or chronic pain in India. With, again, the proliferation of these pain management centers and all kinds of new things popping up in this sort of new economy in India. So these are some of the future trends in this.
Thank you both very much. It's an topic that's usually, and an area that is under research, not just overseas, but especially in India. And I think, and it's amazing all the work you've been doing. And thank you very much for your contribution. Thanks a lot.
Thank you.